we're trying to do is then increase the amount of growth hormone so that we can increase that person's growth, okay? So stimulated by our GHRH that we were talking about, it stimulates that production of our IGF-1, which we had already talked about, right, that promotes growth. We want to see IGF-1 in these patients. You also see that if they're looking at their longitudinal bone growth, we like to see this happen. You want to try to do this before puberty because when puberty occurs, a lot of the time you're not going to see as much growth. And so we're trying to say, hey, can I stimulate this to get that patient to be a little bit taller? This is definitely a patient preference thing because some people may not want to have any type of growth hormone for them to get taller. So they asked me this about my daughter. My daughter's going to be pretty short. They said maybe 4'10", maybe 4'11", right? And so the question was posed to us, would we want to do growth hormone? And my answer is no. Like, I don't remember I told y'all I'm the pharmacist who doesn't like meds, right? So again, I know. So making sure that you understand that this isn't something that always has to be given. To some people, they're perfectly fine how they are and you just leave them, and that's their choice. But it is something that you can always offer. Required during our childhood for them to try to get to a normal adult size. Does not always mean that we get them to that size, but that is what we're aiming for, and that is how they are going to dose these medications. You see that you also have the potential of abuse, and of course no drug comes without any of our side effects. So you see that you have the where you can increase muscle mass, essentially, if somebody was abusing this. It's kind of like how people use testosterone in a way. You can see them using growth hormone also, okay? So understand that there's lots of different things that could occur, and understanding that once those growth plates close, that you're less likely to see any additional gains in the height of that patient because those growth plates have already closed. Thing to note is that these are not controlled substances, okay? So people can easily get them because they aren't controlled. Don't you guys give them to them for them to do these things, okay? But that is how they are used, and that is how a lot of patients will get stuff like this online. And now that we have hims and hers, like those websites, they're seeing doctors like virtually who are prescribing things that sometimes people don't need, okay? So you can see a patient coming in on stuff like this to you, and you're like, oh, why are you taking this? Ask those questions. Don't just refill prescriptions. I always tell y'all that. Don't just refill something because somebody's been taking it. So looking at your growth hormone, your clinical use, and when you're going to see this. So again, in your children who are not growing and you see that their levels of their growth hormone are low, that's something, again, to be posed to the parents. Chronic renal insufficiency, a lot of the times you'll start to see this because, you know, every time you take a child to their pediatric appointment, you're going to get their height, you're going to get their weight, you do their blood pressure, all the things. They can chart that to see where they are in their percentile. So you will tell the parent, like, oh, your child is in the blah, blah percentile for their height. My daughter is in the 4th percentile for her height, right? So that means that 96% of the kids her age are taller than her, okay? So like when you see those things, that's your hint to say, oh, we could potentially do something for this person. We could potentially give them something to help them catch up in their height. And then your Prader-Willi syndrome, again, something that's very rare, comes with a lot of other things. You would just be seeing that this is on someone's chart. You could just ask. And then your patients who are adults, when we see this, because of the different mechanism that you have with that building the muscle, that's why we're using it in our adult patients. So our patients who have HIV, a lot of them, bless you, will have poor appetite. Some of them will just have that muscle wasting syndrome that's happening to them. And so you can see where we can benefit from giving them this medication because it can try to help them build up that muscle mass again. Also understanding that we also need to help them with their appetite if that's why that's happening. Growth hormone deficiency, again, that's just something that is always going to be present, but if you see that those levels are low, you can give them to them. It's just to kind of help balance them, not that they're going to see any real growth after that. In your short bowel syndrome, essentially what that is doing is you can see that it'll increase the the amount of absorption that these patients will have, which is already decreased because they have a shorter bowel. Okay? Thyroid stimulating hormone, or our thyrotropin. We talked about this when we were looking at our thyroid and how this is essentially helping our body know if we need some thyroid hormone. We can also use this for a diagnostic test. So this isn't something that you would be prescribing. This is only something that you would be using in a clinic type of setting for us to diagnose a patient to see if they have any type of thyroid cancer or anything else after you try to remove the thyroid. If any of it is still remaining there, you'll see some responses from this. So what you're looking at here is your thyrotropin alpha is the med that you would be administering at that time. All right, your ACTH or your corticotropin. So when we're looking at this, this is going to help us see if there's any issues that are wrong with your adrenal cortex. This is what y'all talked about already today. So you have primary insufficiency and secondary insufficiency. When we're looking at this, the way that I try to think about remembering it is your primary insufficiency is saying like that adrenal cortex is broken, right? So if I had a car and my battery was dead, it doesn't matter what I'm going to do, my battery is dead, right? So nothing is going to make it turn on. So all regions of my battery is destroyed. When I'm looking at my secondary, this is usually because I've had some type of suppression that has occurred. Most of the time it's going to be us giving people meds, and we like to use steroids, and we'll talk about steroids later, but the longer or the higher the dose of a steroid that you give a patient, the more likely their HPA axis is going to be to shut down because it has the drug that's doing it for it. So the body gets lazy, right, and it says, produce this thing for me, okay? So when you look at this, that's just sometimes, depending on how long they've been on that steroid for whatever reason, that HPA axis has to then regain its ability to work. It has to wake back up again. And so that time that it takes for it to wake back up again will vary. So if you give cosentropin, sometimes you'll see very varying responses depending on where your patient is and the time that you've given the med and everything. So if you have your cosentropin injection in a patient who has primary, secondary, or normal. So normal is the most clear one for us to see. If I gave cosentropin to a patient who has a normal adrenal cortex, what we should see is that cortisol levels go up, right? A typical response, because now I've added more on top of what their body was already responding to, what their body was already doing. Now going back up to my primary. If I had primary, what we were just talking about, right, was the battery was all the way dead, right? So there's nothing that I don't have anybody to give me a jump, the battery is dead. So when I give that cosentropin, because my battery is dead, right? So if I put my key in the car and I'm turning it and I'm turning it and turning it, nothing's going to happen, okay? So then that's where you see that it will remain low. And then when you have your secondary, it will vary depending on what's going on with your patient, how long they have had that suppression occurring, several factors, okay? So just understanding this is, again, that loop that we talked about in the very beginning with our end result being our cortisol. So our cosentropin is essentially trying to mimic that and get a response from the body as well, okay? So it will vary. On this, same type of idea of what we were talking about, right, on the previous slide. So go through, and you can see the same exact thing from the previous slide, being on here. So if it were a patient who had primary adrenal insufficiency, what are we expecting to see? Okay, and then if we had secondary, what are we expecting to see? Varies, depends, could be low, but varies. And then if we have our normal patient, what are we expecting to see? Increase, okay? So, all right, FSH, LH. So when we're looking at this, essentially in the name is what we're seeing. Whenever we talked about these in the very beginning, remember I said kind of think of them as like ovulation, sex type hormones that we're looking at, and we're using them and administering them to get some type of result. So when we're looking at this, we're using this for our women who want to become pregnant. Let's say they are having difficulty becoming pregnant, or if they're having difficulty with ovulation, this is going to help them through that process. And it can also help men who have low levels of sperm as well. So those are our clinical uses that you have, and then here are our different agents that we have. So phylotrophin alpha and beta, urophylotrophin, and lutrophin alpha. So again, these pay attention when you're going through these drugs to know which ones are used for which indications, because every drug does not go with an indication, right? So both of my indications, ovulation and male infertility, so just think of infertility in general, right? I can use both of these meds, the first two, your phylotropins. When you get down to your urophylotropin and your lutrophin, those are specifically for ovulation. So for our women to ovulate, they're not used for our males, okay? So this is male and female, your first two. These are only for your females down here at the bottom, okay? Pay attention to that whenever we look at it. Don't just try to word associate on this. We see that all of these end in tropin, right? But then if you don't know which ones go with which gender, that can become a problem, okay? All right, when we talk about prolactin, again, when you think about this, you think about women, they've had a baby, we talk about milk production, that's when we typically think about prolactin because it is the main hormone that we have that causes lactation to occur. So that's why we want bonding and all those other things so that the prolactin level can go up and therefore the mother can produce more milk. So when we look at this, several different things that are coming into play. What I want you to understand is going to be on the next slide and just understanding what it's for. So prolactin, we think about lactation. And then the third bullet is where I want you to focus. So when you're looking at this, most of our other hormones, they have like a negative function that goes back up and says, hey, stop it, I don't need it anymore. Here, what you see is that dopamine, which is an inhibiting factor now. It's not stimulating something. So dopamine comes and says, hey, prolactin, stop it. We don't need it anymore. Whereas all of our other ones that we've been talking about, they were kind of stimulating, and you could see them kind of going in and shutting themselves off and coming down with an in cascade. This one is not like that, okay? So this one, the prolactin, is inhibited when we have our dopamine. So here are agonists that I want us to look at. Dopamine agonist, okay? So an agonist is trying to increase something, right? An agonist is mimicking what my body already does. So when I look at my hyperprolactinemia, this is going to say, because remember my dopamine is stopping something, right? So now do you get what I mean by like all of our other drugs, whenever we said an agonist, it was like that hormone that we were being an agonist of was the thing that it was agonizing. This is two different things. So prolactin is associated with dopamine, and dopamine is what is going to agonize or increase what's happening with our prolactin, okay? So when you look at this, prolactin inhibiting hormone, all right? That's what my dopamine is doing. So under here, again, all I want you to understand is your clinical uses that we have. So if somebody has too much prolactin, which can happen from several different reasons. Sometimes it can be other meds that they're taking. It could also just be that their body is producing a lot. But a lot of times what you are going to see whenever you see this is going to be other meds. And it doesn't necessarily mean that you have to do something at that point, right? Sometimes we can just say, hey, are you experiencing side effects from it? Like, are you experiencing breast tenderness? Do your breast leak milk and there's no baby, right? If somebody hasn't had a baby, their breast should not be producing milk. But sometimes because they have the hyperprolactinemia, they could be potentially making milk as well. So like you ask those questions. If not, sometimes it's something that's okay to ignore. You'll start to snoop around, do a full workup to see why that could possibly be the thing, because it could be an adenoma that you see there, and then you see also that we can treat our acromegaly with this as well. So again, several different options that we have on how we can use these, and then we're going to talk about our options that we have because they're a little bit different than what we've been talking about before also, because guess what? These are oral. We were talking about our other ones. Remember, we were always injecting. We were injecting. Now this is the first one in this block that we've hit, in this lecture that we've hit, where now it's an oral option. So you have your bromocriptine and you have your cabergoline. When we're looking at these are two different drugs. One is not the big difference between them is essentially your dosing regimen. So this is the only time where I want you to look at this to see what's going on. You see that here we have your bromocriptine, you're taking it every single day, whereas your cabergoline, you're taking it twice weekly. So if you think about that, especially if you're writing, remember I tell you if you're doing something and it's not every day, write the 2 days that they're supposed to take it in that week so that they know. But this kind of looks a little, your cabergoline looks a little bit more patient friendly. Also, you see that you have less nausea associated with your cabergoline than you do with your bromocriptine. So again, patient-friendly wise, if you had to choose between the two and you see two of them, your cabergoline is your better option for you to choose because it's just less side effects and it's more, it's less of a dosing regimen for that patient to take, okay? But you see some other GI issues that we have, orthostatic hypotension, just very basic kind of things, tiredness, okay? So remembering on this, I do want you to remember the difference between the dosing regimen and the side effect, okay, so that you understand why one is preferred over the other. All right, so your dopamine agonists are working by doing which of the following? Are they increasing my prolactin or decreasing my prolactin secretion? Are you saying up or down? Down, right? So again, remember, this one is the one that's kind of opposite. Agonists, we usually are like, oh yeah, agonists are keeping things going. This agonist is inhibiting, okay? What is something else that's different about these dopamine agonists that I just talked to you about versus all the other meds that we talked about this lecture? Oral, right? So the route is also a big difference that we see here. All right. This slide is just telling you about all of the different hormones that we have talked about so far, telling you what their functions are, where they're working, and then what's inhibiting them, what's making them stop their production, okay? So not something that I'm never necessarily going to ask you, but if you want to go back through and say, like, hey, how are these things working? Again, focus on drugs, mechanisms of our drugs, how they're working. This is just a summary of everything. Okay. All right, posterior pituitary hormones. So we don't have a lot, but they are things that we see quite a bit that can come up. Most of the time, this is going to be on the inpatient side of the house that you'll see some of these things. So I don't know how much you will potentially touch on them. You could be the one who diagnosed somebody with some of this stuff. So we'll look at a few of these. So your antidiuretic hormone. This is a hormone that is going to come from your posterior pituitary to the kidneys, okay? And then from the kidneys, it's going to go to the blood vessels, and that's where it increases your water reabsorption, and it increases your vasculature pressure, okay? So when you think about this, I am thinking about water reabsorption, okay? So my fluid levels, and then I'm going to think about some blood pressure stuff. When we look at this, this is just gonna, there's a lot of different things. I think y'all are gonna talk about it probably. Did y'all talk about this already? Not yet? An endocrine? Hasn't hit it yet? Yes? No? Yes? So y'all will look at this in more detail. I'm focusing on the drugs, okay? So understanding that background mechanism of what ADH does will help you. And when we talk about our vasopressin, this will help you, but understand I'm going to focus on the drugs, so that's what we're going to talk about now. So mechanism. It is responding and being released because things have dropped. Several things could have dropped, right? So my volume could have dropped, my blood pressure could have dropped, because what did I say that ADH does? It's going to increase those things, right? Because I'm going to retain water, I'm going to increase the pressure in your vasculature. So either of those things are going to say, hey, I need you to come out. I need you to be secreted so that I can get those things back up. I can get the blood pressure back up. I can get the volume back up. So when you see your levels of your sodium here, I don't need you to remember the different numbers unless I talk to you about it. I'll let you know if I'm going to get to that. But I don't think I'm going to make y'all remember. I'm going to tell you if it's hypertonic or hypotonic. I'll tell y'all. So this is our normal serum level that we want our patient to be at. Also make sure that you're not looking at falsely, sometimes if we're giving a patient a lot of fluid, this may look lower than what it actually is because we've diluted it, right? So if I gave you a bunch of fluid, a lot of your sodium, different things like that, electrolytes will look like they're low, but it's just because I've watered them down, so to speak, okay? So make sure that it's not a dilutional lab that you're looking at. So you see your hypertonic is over 145, right, because that was our upper limit, and our hypotonic is less than the 135 because that was our lower limit. So whenever you're looking at your hypertonic, you see that your ADH is saying, hey, let me get some reabsorption to come back in, and therefore I can have that retention, and then I'm going to get rid of more of my sodium, and my urine is going to be more concentrated, okay, because I'm trying to get rid of a lot of that sodium because I said my levels are already high. And then here with our hypotonic, you will see that your ADH is not going to be secreted, and therefore we're just negative feedback. Our body is just staying in homeostasis. We're okay in this situation. So recap, you have your ADH, right? And then let's say you have hypovolemia, hypotension, usually the two that I stick to. I won't dip down here, you might in other classes. But hypovolemia, hypotension occurs, and so your body is going to say, hey, I need to release that ADH so that I can retain some water, and I can increase the arterial pressure, because these are the two things, either one of these, right? But these are the two things that I'm going to see if I secrete ADH. And then therefore, I'm going to see an increase in those two end products. If I have a low level of sodium, right, so I'm hypotonic, you're going to try to want to get rid of water. So therefore, you're not going to secrete ADH, right? Because if I secrete ADH, I'm going to reabsorb water. So if I'm hypotonic, I don't want to do that. If I'm hypertonic and I secrete ADH, I'm going to keep some of that water, and then I'm going to get rid of my sodium in the urine, and I'm going to dilute it out a little bit more. Okay, so understanding what happens in these situations are important for you to understand, not the lab value, because I will tell you hyper or hypotonic. Okay, so you just say, hey, this is what is happening. This is what I need to do. Do I want to see ADH or do I not want to see ADH? So this is another example of essentially what's happening in this person, right? So she's working out, she's skating, she's going, and she's going to sweat. So with sweat, she's losing volume, right? Because it's coming, she's sweating. As she loses her volume, what starts to happen is your ADH is then going to be secreted or inhibited. Secreted, right? Because I said ADH is going to try to reabsorb some of that fluid. So it's going to be secreted, and it's going to act on her kidneys to retain that water and to increase her blood pressure. We're trying to retain the water, because what happens if she keeps losing fluid? She's going to be dehydrated, right? And we don't want that to happen because we want to let her keep rollerblading, okay? So our ADH comes to save the day. Over here, you see that, again, coming from our posterior pituitary, you're going to have the vasopressin that's going to be, or your ADH that's going to be released. You have V1 and you have V2. Very important to remember, because our drugs, these are going to be our drug mechanisms. So your V1 is working on your blood vessels, and then you have your V2 dealing with the kidneys, right? So this is why we see that increase in the pressure, and then that's why we see our absorption, right? Because these are the two main things that I told you that I was going to be focusing on. So V1 vessels, 2 kidneys, okay? V2 for your kidneys. And then understanding that your vessels are going to cause that increase in the blood pressure when ADH is released, or your vasopressin. And then your kidneys are going to say, hey, I need to retain some of this water, this fluid, so that my patient isn't going to be dehydrated, okay? So when we're looking at our drugs, we have what I've already told you about your ADH. So when you're looking at your antidiuretic, my antidiuretic is saying, I'm trying to retain some of that water. Because remember, diuretics are getting rid of it. So if I'm an antidiuretic, I'm keeping it. Okay, I'm against diuresis, all right? So antidiuretic, and we said that that is with our V2, right? Because V2 is dealing with the kidneys. When you're looking at the vasoconstriction property of it, you see your V1 alpha, or we said V1 was all of our vessels, right? And so my end result of that is going to be an increase in my blood pressure, okay? So this is our mechanism that we're looking at of what our ADH is doing. Adverse effects that you can see, depending on what's going on, so you can have water intoxication, right? I overdid it. You can also see where you have hyponatremia, but this is because it's going to be dilutional, right? I reabsorbed so much water that now I've kind of like diluted out what my labs really look like. Okay, same thing if I were giving them too much fluids, you can sometimes have a dilutional hyponatremia. It's not a true hyponatremia. And then your vasoconstriction, so if somebody already has high blood pressure, things like that, of course we need to be careful. We would be monitoring those patients to make sure that we're not sending them over the edge and having any type of other coronary artery disease or a stroke, any of those things happen to them. Okay, so our clinical use. There are several different things that we can look at here. So you have your diabetes insipidus. Don't mix this up with what we're going to talk about later when we're always talking about diabetes. This is not that diabetes, okay, because people will mix it up. So essentially when you're looking at this, a lot of the times what's happening is that your kidneys may not be responding to what we're doing with that ADH, and so therefore you can have a lot of that fluid being either released, or you can have when your fluid is being out, where their blood pressure, right, will be low and their body is not responding to it. Okay, so it's an inappropriate response to our ADH, or even triggering our ADH to be released. Okay, so just think about it as like these things are not working how they normally would. Our normal feedback system is not working. So what you can do is you have, we used to use vasopressin or our ADH that we had, but now we have desmopressin, which is better, used more commonly, used for a couple more things than just diabetes insipidus. Varices, we can also see them used there. Shock is a big one that we will see this used, especially if you're an inpatient, if you're in like an ICU type setting, we'll see this used quite a bit. So just make sure that you're understanding these are different options that we have to use for that last line. I'm not going to ask all that, but this comes up a lot because there are some people who have been practicing for a little while. They always ask about like, oh, well, the algorithm for asystole. I'm not going to ask you that. It's just for people to not ask that question like every single semester. So okay, so shock, varices, and then your diabetes insipidus. All right, so my products that I have. Again, pay attention to the route that these medications are going to be given, because again, that plays a role in how you can treat your patient, what setting they need to be in for you to treat your patient, okay? So we have our desmopressin. Desmopressin, again, great medication. One of the big benefits that we have with our desmopressin is that it doesn't have that extreme pressor activity that we can see, and there's lots of different formulations that we can give it in besides just IV. So we have the nasal formulation, we have an injection, and we have a tablet, okay? Especially when I see something like a tablet, that's good for me as a provider, because now that means my patient doesn't have to stay in here with me, right? I don't have to watch them, I don't have to worry about them, because I can let them take these meds and they can be at home. Mechanism of action, analog of my vasopressin, so kind of trying to get that same response. But the big thing that I see here is that I don't have a lot of that pressor activity. Okay, so what that means is, what does that mean? If I don't have a lot of pressor activity, what's happening with my blood pressure? Is it going up, or is it staying where it kind of normally rides? It's staying, right? So this is beneficial for somebody who does have any type of CAD or anything else that we need to worry about with their blood pressure, because now I'm not going to affect that as much. I am just affecting the ADH response. I'm just trying to get that, the kidney response, not the pressor response, okay? So antidiuretic to pressure ratio, 4,000 times that of my natural body, my vasopressin, right? So remember, whenever I'm making a drug, I'm trying to make it do something better than what my body normally does, or make it strong enough to shut off or compete with what my body normally does. Okay, so this is very effective. Again, what you can see is that hyponatremia that can occur, and because that is involved with several different things, right? Sodium is involved in lots of things in our bodies. You can also see seizures that could occur due to that electrolyte imbalance that could occur, okay, from them taking the meds. Whenever I'm looking at, again, clinical uses, same things that we talked about already here with our diabetes insipidus. Remember, this is the one that we are using now, more likely for that. You also see polyuria, polydipsia. So in certain situations, especially in ICU, we can see where this medication is used, and that's why I said it's one of the ones that we see used a lot. So essentially, they're not responding how they should be responding, so we will give them this medication to help their body get rid of and stop trying to fill that excessive thirst that they're still feeling and going to the restroom. We talked about bleeding. We said varices earlier, but this is more specific, looking at your hemophilia and your von Willebrand's disease. So when we talk about this, you see this is our IV formulation. Remember, we had all those different formulations, oral, nasal, and IV. So in this situation, our patient is going to be likely in the hospital for them to get this medication, and essentially it's going to try to help them control the bleeding, decrease the amount of bleeding that this patient is having, by enhancing different factors that they have available. So I just want you to understand what the clinical use is. Don't need you to remember all of the mechanism behind that. Just know what your clinical uses are. And then your nocturnal enuresis or your bedwetting. So if you think about this, most of the time whenever we see this is going to be in a child where it's not age appropriate anymore for them to be bedwetting. So like let's say it's somebody who's a teenager and they never stop bedwetting. Okay. Benefit to this is that you see that you have the nasal formulation. So if it is someone who's 8 or 9 and they're still doing that, we have a nasal formulation. We also can use our oral tablets for this as well. So again, it's trying to shut down or decrease the amount of urine that is being produced so that they're not going to the restroom while they're still sleeping. Okay. So several different uses that we have when we're talking about our desmopressin. SIADH, or syndrome of inappropriate antidiuretic hormone secretion. Did y'all talk about this yet? Yes? Okay. So, you know what it is. That's all that this is saying. What I want you to understand and what we're going to look at is going to be the treatment. So, making sure that again, it's not a dilutional hyponatremia that you're trying to treat, but you want to make sure that it's actually like they have low levels of sodium, and that is the problem, right? So they're continuously producing that ADH, and then that means that they're going to be retaining more water, which is why we see that dilution occur of that lab value, okay? So that's why you see the hypoosmolality, that's why you see the hyponatremia occurring in that patient, okay? So their body is inappropriately having that ADH being secreted. Signs, I will tell you what they have, so this is just for completeness. You don't need to remember all of the signs and symptoms because I'm going to tell you, okay? So when we're looking at our treatment, this will vary depending on the amount of hyponatremia that the patient has, and that's going to vary, of course, depending on the patient. And then also, are they symptomatic or not? Sometimes when we find this, especially if a patient is in the ICU and they're unconscious, there are no symptoms that are being displayed, right? But there are times where your patients will come in, they're like, hey, there's something going on with me, you're gonna get your lab values, and then you'll start working it up and you'll figure out that they have SIADH. So you have acute or chronic. Acute is less than 2 days and chronic is over that 2 days. And then you're also gonna need to make sure that you're gonna get all of these lab values to work them up. So honestly, when you're looking at this, it depends on what is going on with your patient and how bad off are they. Is this an emergency for us to fix, especially if our patient is symptomatic, right? Versus do I have some time to kind of slowly fix my patient and what's going on with my patient. So our big thing when it comes to the treatment, which is what I'm worried about, you have to make sure that you're doing it appropriately because you can do it too fast and then you can cause your central pontine myelinolysis, CPM. So if you give them their meds too fast, you can cause this. When we first saw this, when I was doing my residency, our patient was in a coma, and he was between 19 and 21. And he had cancer, and he had a seizure, hit his head, which is how he ended up going through all of the issues, and he was in the hospital. And he hadn't come out of the coma. And so we saw that he had SIADH, and so we were trying to correct it, but then they didn't know how fast to correct it, because if they corrected it too fast, then we would have caused CPM in our patient, and then we won't know until and if that person wakes up. Okay, so that's why this is like a big deal that you'll hear different people handle it differently. Some doctors are very, very cautious and they go very, very slow, and other providers might move a little bit on the upper end. So it just depends on their experience and what they're comfortable with. Okay, so understand that you might see this handled in a couple of different ways, like in real life. So when you're looking at this, you want to make sure, again, indicated in your patients who have symptoms, right? So this is where I was telling you, like, do you have time to slowly treat your patient, or is this an emergency? When your patient is symptomatic, respiratory arrest, coma, seizures, things like that, as to how they're presenting, then you're going to need to follow the protocol that we're going to look at on the next slide. Moderate to severe hyponatremia, if it's been less than 48 hours, again, that was that acute setting, was less than 48 hours, that again, we would see where we're going to try to treat our patient. So for this exam, my exam, what you would be doing is you're going to try to get their serum, their sodium levels increased 0.5 to 1 milliequivalents per hour, but not more than 10 to 12 in that first 24 hours. So this is the rate, and you trying to control how fast we're going to increase that lab value, okay? So this is a very like going slow kind of thing. I want you to remember the rate at which we would be doing that, and then what your maximum is, so that this whole bullet right here, just kind of remember this. Again, you will see some people where they're going to be going a little bit slower. Nothing wrong with that, just trying to make sure that we are not causing CPM, because if we're going too fast, CPM is the end result of that. Different options that we have here, you have your hypertonic saline, we have diuretics because we're going to try to diurese that patient. You have your vasopressin 2 antagonist, right? Because I don't want the ADH actions to occur. So I have my antagonist that I can be using, and then water restriction. If your patient is still awake, the water restriction is very important, because a lot of them will have family members bring them things. A lot of people will have, like, fluid restriction in the hospital is like one of the most, it's very difficult. Especially if the nurses aren't walking around and they don't see the patient and stopping the patient. So if you are going to put somebody on a fluid restriction, make sure that it's in the chart, and make sure that you actually touch bases with the nurse so that they know, like, hey, I'm monitoring this patient eyes and nose. I need to make sure that they're fluid restricted so that you know if your meds are working. Because if I'm trying to get rid of water, but I'm consuming a lot of water, I'm going against what I'm trying to treat, right? And then you're going to think your treatment isn't working, when in actuality it's the person who's just drinking water, or they'll have smoothies, or they'll eat a bunch of ice. Like, there's lots of ways, of course, to get water. So just make sure that you're paying attention to that. And then also, if we're running other IV bags or other meds that have saline in them, that's also fluid that's going into that patient's body. So take all of that into account whenever you're looking at this. In my patient who is asymptomatic, so over 48 hours is the chronic portion of it, and asymptomatic. You can see this occur. This might be a majority of your patients where they're walking around and they have no idea, right? So essentially what you're doing here is you are less aggressive. They're not going to need to be in it's not as an emergency, right? Because I've been walking around with it and I didn't even know. So fluid restriction, and then you have your antagonist, again, that you would put on board. So the bottom two things that we talked about in our emergency situation are now going to be the two main things that we're using in our asymptomatic chronic patient, okay? So just understand what those are. When we're looking at our antagonists, we're going to talk about the two that we have available. We have conivaptan and tolvaptan. So again, this is that same chart that we saw on the right. So again, remembering our V1 versus our V2, okay, and understanding because these drugs have different affinities for each of these receptors. So when I'm looking at my conivaptan, I also see something that's unique about it is that it's IV, and then I see that it doesn't care. V1, V2, it's not discriminating, right? Whereas when I look at my tolvaptan, I have an oral formulation, okay? And I see that I like V2 more than V1. So I'm more worried about that ADH, the kidneys, the fluid reabsorption, than my vasculature, okay? So this is also very beneficial for us because in a patient who is asymptomatic and they're chronic, especially if they haven't been hospitalized for something else, I can treat them outpatient, right? I don't have to have them inpatient because this is an oral, this is a pill that they can take. So just looking at this, you see that these are, again, vasopressin antagonists. If you remember that, you can kind of remember what they're doing. They're antagonizing what I would typically be seeing with my natural release of my posterior pituitary. My clinical use, hyponatremia is kind of what we're talking about here, but you can also see us using this in some of our heart failure patients. Just know that those are the two things. Mainly what we're talking about right now is our hyponatremia. And then you see that I can also use it for my patients who are hospitalized. It again depends on your patient presentation. If they're not awake, then of course you cannot give them tolvaptan because they can't swallow the tablet if they're in a coma, right? Or if they're in PO at that point. If they can't have anything by mouth or if they're continuously vomiting, things like that, that will push us to use our conivaptan, which is the one that's IV, okay? So, conivaptan, I told you on the previous slide, V1, V2, doesn't matter. It is an equal opportunist, okay? So, I'm giving this IV, and I remember that one is IV because it has IV in the name, right? Conivaptan has IV in the middle. And so, when I'm looking at this, I'm saying, hey, I'm trying to help this patient. So, I'm going to hit both of these receptors, and the big thing that you're going to see is I'm going to stop. Well, I want to talk to you about this first. When you look at this med, running it is going to be very important, but also making sure that your patient is, especially if they're not in that emergency setting where we're using it, if you are going to admit a patient to treat the patient, again, have their buy-in. Don't just make them feel like they're forced to come into the hospital to get treatment because we do have another option. But as I say, okay, so here we're trying to get that serum, the sodium levels up. So again, they have to be hospitalized because we said that this is going to be IV. Talk to the patient. They may not want to be. You also see our heart failure off-label. So again, I told y'all what I'm really worried about is going to be the levels of our hyponatremia. And then your osmotic demyelination syndrome. So when we're looking at this, it's the same thing that happens when we were talking about our CPM, right? If I correct too fast, if I am trying to get that hyponatremia corrected too fast, so over the 8 milliequivalents in a 24-hour period, then I can see this side effect occur. If that occurs, you see that we don't have great outcomes. So you can have seizures, you can have death, you can put the patient in a coma, you can, there's just several things. So this was what I was also asking my preceptor about. I was like, well, what if we do overcorrect or we correct too fast? How would we know? And she goes, if they wake up. If they wake up, sometimes you'll see where they'll tell you like, oh, they can't move a certain part of their body, or oh, now they can't swallow. Like there's several different things that can potentially happen. But it's better for us to correct it than to not correct it. So you just make sure that you stay within that rate, and you should be fine with your patient. What else did I want to tell you about this? Oh, when you're looking at this medication, write this for me because it does have a black box warning. Clearly, you have to be in the hospital for it to be initiated. This This isn't something that should be in a clinic. It should be initiated in a hospital, okay? Because of that demyelination. So this warning, you could just put the black box warning right there. Okay, your tolvaptan. So when we look at our tolvaptan, this is the one that I told you was an oral option. This is a good option for patients who don't want to be hospitalized, who are okay, they deal with taking their meds. This is also good for a patient who already has some type of coronary artery disease, okay? Because I have a higher affinity for V2 than V1, all right? So if I have a higher affinity for V2, that means that I'm trying to target those kidneys more than I am that vasculature, which is going to be good for that patient, okay? So PO, higher V2 more than our conivaptan. Remember, our conivaptan was only IV, and remember, our conivaptan didn't care. It was V1 and V2, okay? So big difference between these two meds. Your clinical use, same thing that we saw before. So treating that hyponatremia. You can also see if our patients have SIADA, heart failure. These are the two things that we talked about already. Black box warning, same thing that we talked about with the previous slide, except here it's labeled properly, black box warning, okay? So again, initiating it in the hospital. So just because it is an oral medication does not mean that they just get to take it, like you get to prescribe it and they go. We want to see how they react to it to make sure that they are not going to have that osmotic demyelination occur to them as well. Okay, so that, again, that quick correction depending on how their body responds to it, because we can't tell how a patient is going to respond to that medication until they take it. So once they take their first dose, that reaction that we see should be the same reaction that we're seeing every single time. And again, if this is something that we're worried about, we counsel our patient and tell them, hey, you just come back. But they're taking it at the hospital the first time for us to see how they're going to respond. They will be hooked up to monitors for us to make sure that they're responding appropriately. They go home, and then you just make sure that they know, hey, if you're experiencing any seizures, if you're starting to feel fatigue or any weakness in your muscles, then you need to come back. And again, you would take them off of this bag. Yeah.
On the Vaptum, since you said that there's mutism or dysphagia that they can experience, can speech therapy help with fixing that, or is it a permanent thing that they?
So I asked that question too. So they were saying that it can be permanent depending on how soon you catch it. So essentially depends on your patient and if they can tell you that it's happening sooner rather than later, right? Because the more time that you keep running the med, the more damage that is done, and then the less likely you are to be able to reverse it. That was the answer that I got. Because I was like, well, if we do it, then like it'll come back. Right? Not always. So she said, not always. Okay, oxytocin. So oxytocin, when we think about oxytocin, again, coming from our posterior pituitary, and when we look at this, we think about oxytocin as like the thing that makes everybody happy, right? And so when we're looking at this, pregnancy is a big time where we see this, and we also will see us hang bags for people to go into active labor when we're looking at our oxytocin. So it's going to help with contractions, and it's going to help try to get that baby out. So when we look at this, you can also see that oxytocin plays a role in sperm maturity as well. So we definitely heavily related to pregnancy, but we have that sperm maturity also that can occur whenever we're giving our oxytocin. So already told you the mechanism when we're talking about the women. So when you're talking about pregnancy and you're hanging it, you can see that you're going to help stimulate contractions. When we talk about breastfeeding, essentially that's where you can hear or see a letdown happen essentially in a woman. So it could be their baby, it could be any baby. They hear a baby crying, the oxytocin starts to get released, and then milk gets released from the breast, okay? So I had my son. So after I had Cinco, I was like, okay, I hated hearing babies cry. It was the worst thing ever because I, of course, went back to work. And there was someone who had their baby, and I was in the back of the pharmacy. The pharmacy is loud. The waiting room is loud. Everybody is yelling because they said they've been waiting there for 10 years, all the things, right? And so this person, like, I kept hearing a baby, and I was like, maybe I'm going crazy because I was always hearing babies after I had my first kid. Like, I always thought babies were crying everywhere. So I went out to the front, and I was like, is there a baby crying? And they're like, yeah, the baby's been crying for like 20 minutes. So I walk out to the lobby, and I was like, do you need help with your baby? The lady, it was a grandma who got left with the baby, and they were doing cloth diapers, but the baby had pooped. The mom didn't leave any cloth diapers, and she couldn't find the mom in the hospital, and I was like, okay. So I take her to the bathroom. I was like, we can figure this out. I was about to rig it up, and the mom walked in there. But by the time I was finished listening to this baby cry, my shirt was soaking wet because I was releasing milk because I'm hearing somebody else's baby cry. And my friend, when she had her baby, I couldn't even hang out with her at all. Anytime I saw her baby, which was worse than my own kid, I saw her baby like milk. And I was just like, okay, we got to get out of this stage. And I had contractions every time I heard babies cry for 3 months after I had my child. So like you will hear weird phantom things that make people think that they're crazy. But me and oxytocin are not friends, okay? So when you talk about Pitocin, me and Pitocin are also not friends because this is what we try to use to induce labor, right? So I did this. I was trying to have my kid. I didn't want any pain meds. I was just like, okay, let's get the baby out. And we hung Pitocin for 3 days. And it didn't work. I ended up getting a C-section. But you have it for labor-inducing, and then you also have it for postpartum bleeding. So after you deliver the baby, right, you have to go ahead and you have to deliver the placenta. And sometimes, depending on what's going on and complications that are from that, you can see where you can get, if you hang the Pitocin afterwards, you can see where we can get some decrease in that bleeding. So very good drug to use until it's not. So consider it very safe, right? The longer you run it, the more likely you are to see that water intoxication, because don't forget what it's doing. Irregular heart rate. So that is the problem that you'll see a lot of times when you're using it for labor induction, and that's what happened to me, why I ended up getting the C-section. You will see sometimes not the mom, but more so the fetal heart rate starts to go crazy. Okay, so if they're just like, oh, you got to lay on your right side because your son's heart rate is going down. I didn't know if it was a boy or girl. I also did that. I was just like really crazy on the first one. So I didn't know if we were having a boy or girl either. So they like turn to the side because the heart rate keeps dropping. And I was like, just take the baby out. I didn't get big for 9 months for nothing. Like, get this baby out of me. So that is a very, very common thing that you will see happen while you're running it. The longer you run it, the more likely you are to see these things occur, okay? So if it's a shorter period of time, usually we're okay. But the longer you're on there, the more likely you are to see this. Very rare, you'll see that anaphylaxis or that postpartum hemorrhaging occur, but usually that we're using it to try to help stop it. So you don't see that often. And then your contraindications. If the baby is already in distress, you cannot give this to them because you're going to make the baby possibly be in more distress, right? So we don't want to do that. That's a more obvious thing. And then looking at the different types of, if somebody is having an increased risk of a uterine rupture because of the mechanism, right, and it's causing contractions, uterine contractions, you don't want to give this to somebody who is at an increased risk of a uterine rupture because that could then happen, and then you're going to have bleeding and all the things that we're trying to avoid, okay? So just make sure that you understand kind of what our uses are, induction, postpartum bleeding, and then looking at your side effects. There's 2 really serious ones, right? Your irregular heart rate of the fetus, and then that rupture or any bleeding after the fact. And then your contraindications are if they are predisposed to any of those things, the adverse effects that we just mentioned, then don't do it, okay? Your memory jogs are listed here, and then when we come back from our break, so take 10 minutes. When we come back from our break, make sure that you get the diabetes lecture up, and there's a actual, the worksheet is posted up there. Did you see the worksheet up there? There's like a piece of paper. Let me see. It'll be up if it's not up by the time you get back. I'll also post it up here. What I need you guys to do is you're going to break up into groups because this is where we're going to teach so that you guys can remember this portion of our lecture. Don't do that.
I'll
Don't
do
do
the
that.
whole thing.
Don't do that.
Huh?
Gas water. So told everybody, but the worst part about that was there was a water crisis. So at that time, the algae water had some water where you could shower. So I go home, I could even shower with algae. I'm on algae. There's no
It's a fact. It's a fact.
the home
It's a fact.
the homemade sauce. Oh, homemade sauce. Can't beat it.
don't like those. I was just wishing the last election to about the roads.
It's okay. I thought they were like by extension, that's it.
Sunny, but
Sorry, it came out of my driving hand.
Oh, from last year.
Oh my God.
And then I checked and it's still making it left. So then I went online and I'm like, and then they like replied if they were looking for my phone. And then they're giving me a refund. That's never happened to me.
This is the CIA stuff. Yeah. We're on
Big old literally no the concrete is so traveled, you can see the rocks. This is cardio. My wife told me it's super easy to run. Like you can walk your way down the line path. On a slide on drugs. Hell no. Really got home on Friday, and I was like, well, where's the issue? Melted my couch, I was like, oh, you're not. And then Saturday, I was at the party. One of them, my four buddies came over, or in town, so I went and saw them. I went to Cowboys that night, lost much. Single red game is terrible. But free drinks. My buddy knew the bartender. And I was just like, hell no. He's got a whole lot everywhere.
All right, everybody. So, what we're going to do is have fun again. And we're going to be happy and we're going to smile. And this is usually the part of the exam that everyone does a lot better on. This is, I posted it on the thing because I saw that it wasn't there. So this is the activity that we're doing for the diabetes lecture. So you guys are going to break up into 12 groups. We need to call out what our group, we'll just go in order like this, like 1, 2, 3, 4, 5, 6, 7, right? 12 ends up being up in the front. So 12 groups. These are going to be your slides that you have that you'll be talking about in the time limit that you have. So the slide numbers are in the parentheses for group 1, group 2, group 3, group 4, and so on. And then it has prompts of the things that you're going to be making sure that you at least hit on, like we did last semester, same thing. I'm going to start, I'll teach, but what I'll do right now is we'll have time until 11:30 for everybody to get together, get what you're going to say together. I'm going to be right up here for questions, so that gives us some time, about 15 minutes, if we need 15 minutes. Most of the time, everybody is done in like 5 minutes with getting this together because there's several of you, okay? So I need, who is group 1? Remember, we need 12 groups. I don't know how many y'all have in here. How many people are in here? 63? 12? 5? Okay, so about that. So can y'all break up into groups of 5? No, we can't, or yes, we can?
Yes. Let's go group.
That's usually what happens. People just turn around like.
Are y'all taking 11? 11?
Yeah, she said one.
It's like group 11.
Yeah.
Okay, we'll be 12.
12.
All right, here's how we'll do it. 1, 2, 3, 4, 5. Group 1. Wait, 6. 1, 2, 3, 4, 5, 6. Group 1. 1, 2, 3, 4, 5. Group 2. 1, 2, 3, 4, 5. Group 3. 1, 2, 3, 4, 5. Group 4. 1, 2, 3, 4, 5. Group 6. Really low. 5. So now you're 6. 1, 2, 3, 4, 5, 7. 1, 2. Another 6. 6. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 8. 1, 2, 3, 4, 5. 9. 1, 2, 3, 4, 5. 10. 1, 2, 3, 4, 5. 11. Small group.
Okay, so 11, group 11 will then pick up the slides for 12. Or I'll do 12. Okay, I'll do group 12.
1, 2, 3, 4, 5.
Okay, it's also the worksheet, the Word document is also on Canvas.
So what are we doing?
Number 1.
Fifteen to 20.
Oh, got him.
If you look at the slides, it also has in the upper right corner whatever your group is. So if you control F, if you can control F your group, it'll bring you to the slides. Okay?
Okay. Y'all want to work on 1 through 4, and then us 3 will do 4. Or 1 through 4 we'll do 5 through 8 on the side. for the questions.
1 through 4?
Yeah, E3, 1 through 4, and then we'll split it 5 through 8.
Okay.
All right.
I'm doing 1.
We'll do 5 through
I
8.
already wrote this. It don't matter.
Drug of choice for pre-diabetes. Where's the say drug of choice? Should be on page 21.
Is that metformin?
Or well,
Yeah, I think it's met.
I'm trying to figure out what
oral. Let's start in order because I got them all in one. Where are we starting?
We're starting at this one.
Pre. Type 1.
Pre-diabetic.
Pre.
Pre-diabetes. Here's pre-diabetes, so it's metformin. And then your goals are right here. It's 6.
Where's the say drug of choice? We're just supposed to know that.
It's just right here.
I see the confusion because it's got both. I think you start on that because it's not as strong. Right.
It'd be nice if you got drug of choice.
That's why I'm doing my Pico on.
Yes.
Like GLP-1 combined with metformin versus just metformin alone. Seeing the differences, see which one's better, more effective.
What is type 1? What different ways to administer?
Type 1 is that
It's
beta cell
independent.
destruction. Okay, so the MDI is the injection, like the shot. And then
Injection or infusion.
infusion. Oh, I see. Okay, that's right. CSI is the infusion.
What's PG?
blood. Oh, oh, I don't know. What are you looking at? Oh, post glucose.
Question. I want to make sure I'm
Don't feel good. Those answers.
to make sure.
Just basically saying if you're on by adjusting the next day.
T1 DM is just type 1 diabetes, and then supplement is type 2 diabetes.
I mean, I'm just trying to do what I can to make insulin type 1 so they can use it for none of these things. I can. I'm trying to come up with one piece of something for us to mention portion. So, where you want to target and more your A1C? Because your A1C is above 7, so it's like, are you trying to get it below 6.5? You're trying to get it below 6.
You can see higher, just adjust it the next day or the next day.
So we're literally gonna be on one station.
Yeah.
You got 20 minutes.
She said 8:30 or 11:30. She's gonna teach the first 15 slides. We're gonna teach.
We're not gonna have time. Wasted fucking class. 30 minutes in. Never go time.
rapids, and most of the time they're gonna take those before they have a meal, right? So I'll tell you like, oh, they have 10 units. 10 times 3 would be 30, so we need to divide by 30. Right? Depending on which kind. I can also tell you the perspective. You guys are also gonna have to remember which one is rapid, regular, like the mix
$20 minutes to do 100 slides.
That's possible. Just gotta have faith.
I got 3 or 4. And then they have 5. And they have 5, 6, 7, 8. But this
Yes, we do.
yeah. I was like memorizing. I'm just looking at the chart and freaking saying like, as you can see, like the freaking like they're all targeting different aspects. So the attack hyperplexy. But you have to attacking insulin, this is attacking glucagon, attacking hepatic. I mean, something I can really do is like remember easy. It's like kind of just like plug it away.
Did she post this?
She did.
I just feel like during the daytime, there's just a short activity, and at night you take the
Where's it at? The prompts. There it is.
this morning after you're constantly eating everything.
I think it would be what you're trying to do, like how low you're trying to go and how quick. Something like this it's quite explain how to run the your ability to is already different complex.
Started with injection.
The diabetic with GLP-1, so from diet, the mind, the top 3 or so, and then this FNGON.
I'm in type 2. But type 1 is like but diabetes.
Need more time? Ready? Ready? Yes. Bless you. It'll probably only be the first 2 groups going today anyway, so. All right. So when somebody has diabetes, they're more likely to have other complications. We will prophylactically put them on meds to try to protect their body. Think about diabetes as like super concentrated and super sweet Kool-Aid, right? You put a bunch of sugar in there and it's just floating around and it's damaging everything, which is why we don't love it, okay? So we want to treat this. We want to make sure that our patients are going to be okay. It is very hard to do because a lot of this is also going to be based off of how someone eats. Do they exercise? You also have different types of diabetes that can randomly happen to some people. So very complicated thing. Also, if you can't get them controlled on oral medications, they may have to give themselves injections, which some people don't like to do. Okay, so depending on what type they have, they may also progress to having to do insulin shots or being on an insulin pump where they're constantly getting that insulin as needed. Okay, so think about this as something that you need to be very sympathetic about sometimes when you're diagnosing your patients. It is a lifestyle change. It changes how they can move throughout the universe in general, okay? They have to carry snacks sometimes if they're hypoglycemic. Make sure that they're counting carbs sometimes depending on how bad they are. So be very understanding and persistent with these patients, especially if you newly diagnose them, and also checking on their mental health after you diagnose somebody with things like this. Things that cause people to have to alter their daily life, make sure you check on them mentally also and have those questionnaires done because it's different for them, okay? Sometimes they can't do the same things and mentally they are also affected. ELOs are the same things that we typically see, right? So remember, we're going to ask about meds, we're going to ask about administration a lot in this lecture, so understanding where people can give themselves shots, things like that are going to be very important. So when you talk about diabetes, essentially what I just told you, right? High levels of glucose, what we're doing with our meds is going to try to decrease those levels of glucose to try to get them back within the normal range. Depending on what other comorbidities a patient may have, we may be a little bit more strict on what our A1C goal is going to be. And we'll talk about those A1C levels as well. So all I want you to know is essentially what is happening, right? Their glucose levels are high. Several reasons could be as to why they're high, whether they're not secreting enough from their beta cells, those beta cells have died, they're destroyed, or they might not have insulin sensitivity. This also, you'll see this in the resistance, insulin resistance increase the heavier a person is. So if you start to see obese patients, sometimes they will have decreased insulin sensitivity, and it could be also a combination of both. Once those beta cells are destroyed, that's it. And so then that is where our patients, a lot of them will end up on insulin. What you're looking at when we're talking about our insulin and just talking about our medications in general, what insulin is trying to do is decrease the levels of glucose that we have, right? So it wants our body to say, hey, I have a lot of this glucose around, let me get insulin to either take it and store it, use it for energy, what have you. There are several different things that we can take and use our glucose for. When you're looking at glucagon, think of glucagon as the opposite of what your insulin is doing. So your glucagon is trying to say, hey, let me increase the levels of glucose. So whether that is somebody who is hypoglycemic, we would want to see this response. If we are looking at several different mechanisms, just understand what insulin is and what glucose is, and you guys are going to get into more detail with this later. When you're looking at this, just thinking about you want a homeostasis and you want the correct response to happen to both of these hormones. If that does not happen, then you are going to have lots of issues that can cause several complications down the road, which we don't want for our patients. Kept telling you that there's two different types. There's another type that we kind of talk about that resembles type 1. So you have type 1 and you have type 2. Type 1, you're going to usually see these in your younger patients. They're going to present this way early on. You also have where their beta cells are usually completely destroyed. And a lot of these patients are going to be insulin dependent very early on because they don't have the beta cells to secrete the insulin. When you look at your type 2 diabetic patients, these patients are going to be older. Most of the time it's going to be because of a lifestyle, but not all the time. So when somebody comes in, if you see they have type 2 diabetes, don't shame them. Sometimes it's also like several things that are happening. Their beta cells could be starting to die and like they're not being regenerated, okay? So like there are several different things that can happen in your type 2 diabetic patient. These are not always overweight patients is what I want you to get at. So when you're looking at this, also the other thing that you want to see is that with our type 2, the big difference between our type 1 is that most of the time these patients may not start automatically on insulin. Unless they present to you very, very high, they don't immediately get issued insulin. You're not going to prescribe them insulin right off the bat. My type 1 person, right off the bat, you know that they're going to need insulin. And then you'll also see what we now call late onset moody. There are several different types, but it's kind of like a patient who is older, who you'll see them like losing weight. They'll have several different symptoms, fatigue, they present, and then you'll get their A1C or you'll get their glucose level, and what you can see is that they have diabetes. A lot of the times, then your second step is to, because of course that they're not younger, is that you then try to see what their beta cells are doing and how those are working, and then you diagnose them with late onset diabetes, and that's kind of like it's kind of a type 1, and these patients will end up also on insulin or an insulin pump, like they're treated almost like a type 1 diabetic patient, okay? Again, there's nothing that would say like the person is unhealthy, anything like that, like it's just something that happens, and we have started to see this more often to where now we have classified it. So type 1 and type 2, your late onset kind of looks like your type 1 patient, and they do become very insulin dependent, okay? This is essentially just telling you kind of what's happening. So you have carbs that are going to come from food. Let me get my laser pointer. Carbs that are going to come from your food. Change that into your glucose, right? Glucose is in our blood, goes throughout our body. What you should have happen is that your pancreas then secretes the the insulin, and therefore your glucose can either be used for energy or your glucose will be stored for us to use it later, right? If there is an issue here where I'm not having that insulin secreted, right, my glucose just starts to float around and it starts to destroy all of these things because it's just, you see all of our G's here, right? So it's just floating around and it's just destroying things. It's just sugar, okay? And we don't want that. So when we're trying to diagnose our patients, this is going to take more than one visit. You'll have several different labs that you can do. What I want you to pay attention to is the thing that we're going to hear a lot is going to be the A1C. The target goal for your A1C is also going to vary depending on which guideline you use. So when you are writing your notes, you need to be make sure that you are putting which guideline you use at that time. These goals and these guidelines change quite a bit, so you know your field that you're in now, you're going to always have to stay up on top of everything. So just make sure that you're understanding that you need to just document. So when you're looking at your A1C, you have less than 5, which is normal. You're 5.7 to less than 6.4, and then greater than or equal to 6.5 is where you will say that somebody is diabetic. This now is where you'll hear people, especially if they're over the 6%, is where you'll hear us saying, oh, somebody is pre-diabetic, and depending on what's going on with that patient, you may or may not start meds for this patient. But once they hit here, they're going to get treated with meds. Always, we need to make sure that we tell our patient about lifestyle modifications, right? So diet, and you can refer them to nutrition. And this, again, is not just for a person who is overweight, because that's what we think about with nutrition, but this is also helping them pick the right foods. We have patients who will come in and they're like, yes, well, what did you eat this morning? I ate cereal. Bad, right? Like, don't eat cereal. We don't want you to eat certain things. But to them, it's like, well, it was just cereal, or, oh, I just ate a bagel. They don't understand the differences that need to be made. They don't understand what is a carb. They don't understand that ketchup and everything has sugar in it. So you have to send them to nutrition to talk to them about those things, okay? So that should always be something that you look at whenever you do diagnose somebody with diabetes. So here, big thing I want you to know, A1C greater than or equal to 6.5, diabetic patient. Okay, these are several different tests. You'll see us use these. We use this to see a lot in our pregnant women. They have to go and they do the oral glucose tolerance test to make sure that they are not diabetic, while they're pregnant. Several different risks come along with that. And then your fasting plasma glucose, just make sure that they are understanding that they can't eat or drink 8 to 12 hours before they take one of these tests, and that's just to see what their fasting glucose level will look like. Whenever you initially diagnose a patient, we like to print out logs for them so that they can understand what their body is doing. Now we have CGMs or continuous glucose monitors, which are very good, and the patient can see like almost immediate feedback in like what they're doing, right? Like it's a little delayed, but that's why I said almost immediate. But they can get feedback to say like, oh cool, I ate that donut, what happened to my glucose level? A lot of people who work out a lot too, they use them because they also want to watch what they're eating. So one of our patients, he lifts weights all the time, and he wears a CGM because he wants to make sure that he's not eating anything that makes his glucose levels go up. Okay, so you can see several patients use them. That's a lot, but that's what he likes to do. Okay, so I told you we have several complications, right? We know that there are several things that can happen based off of how long my patient has been riding this way, how long has their glucose level been high, okay? The longer that it takes for us to figure out what's going on, the more likely we are to see some of these complications occur. So you have macrovascular, microvascular, and then acute complications. This is typically where your patient is going to present initially whenever you're about to diagnose them. So they might be hypoglycemic. They might, hypoglycemia is usually after they've been on meds. Sorry, that's after. Because our meds will do this. This is a big side effect of a lot of our medication. DKA and your HHS, these are things that you will see whenever your patient presents, right? So they'll have very high levels of glucose. Some of them will have different ketones and things like that present in their lab, and that's how you're going to diagnose them. Some patients will tell you, like, whenever they urinate, it smells like sugar because they have that much sugar that when they're going to the bathroom, like, you can smell it. Okay, so several different things. Just understand macrovascular, right, heart disease, all of the things. So that's why when we're talking about some of our different disease states, we'll prophylactically, right, preventative, we'll put somebody on a statin, we'll put somebody on our ACE inhibitor, right, to try to protect them because we know that all of these other things can happen to them. Okay, so that's why we're doing the stuff that you learned earlier, is because that is an outcome of just this disease state in general. Looking at our gestational diabetes, so this is the one where I was telling you we do the oral glucose tolerance test, and we will see kind of what's happening in our patient. If they have gestational diabetes, we do like to treat them. Insulin is our preferred method. You will have some patients who will tell you, I'm not injecting myself, I'm pregnant, and I don't want to do it, right? This is our preferred thing because when you look at pregnancy and how the body is responding to creating a little human, this might fluctuate several times. Insulin is very easy for us to change, right? We can give them a sliding scale and we can say, hey, if your glucose level is this, you do that with your insulin. If your glucose level is this, today you do this with your insulin. It's easy for us to decide what we're going to do. When we use any of our oral medications, first thing with these is that we don't have any data, long-term data that say like, hey, this is what's going to happen if they're using this. But also remember that if there is some type of complication or if we do need to change something, we have to wait for this drug to now wash out of their body, which is going to be a little bit longer, okay? So now we're dealing with the half-life of that drug. So when you're looking at your metformin, which is a big one that you'll see used, or the Liguride, those are oral options that we do have, and we do see pregnant women taking it who have gestational diabetes. What this is saying, discontinue by the first semester. If they're using it for PCOS, the doses are going to be a little bit different, so they shouldn't be using it if they're trying to treat PCOS, which we do use metformin for that. If we're talking about gestational diabetes, something completely different, and they can take it while they are pregnant, okay? Looking at the types of insulin, we're going to have to learn the different types of insulin that we have. So you have your rapid, your regular, and your NPH. We'll talk about all of these, but those are the ones that are preferred. You see that long-acting long-acting is not on here, again, for the same exact reason. We don't want to put something on that's going to be there for a very, very long period of time. If we need to change something, or if their body is doing something, if she's pregnant and she skipped a meal and now her glucose level is dropped, and we gave her something that's long-acting, which is going to continue to work, now we probably made her even more hypoglycemic, okay? So this is just easier for us to kind of turn around and react to, even though that patient is going to have to inject themselves more times in a day, okay? So regular, rapid, and NPH. Okay. So the acute complications that we talked about, the big one that I want to focus on is going to be your hypoglycemic stages. Hyperglycemia is bad. Hypoglycemia is bad. Okay? We think about diabetes and we want to tackle that, but then we forget about the fact that, like, we have patients who are going to be hypoglycemic. Okay? There's several different levels that we look at. So we have level 1, level 2, and level 3. When we have level 1, you do your 15, 15, 15. So what that is 15 grams of carbs, you wait 15 minutes. If their level goes back up above that 70, then you're fine. They don't need another one. If it doesn't, then they get 15 grams again, and then they should be increasing, okay, above that 70. Level 2 is if they have glucose levels that are less than 54. So this is more severe. And then you see that you'll have several different symptoms that are going to be tagged along with that patient. If I give you a question on something like this, I will tell you that I will use these specific words so that you know what symptoms the patient is having. But then what you're doing is now, because they're more hypoglycemic, I'm increasing the amount of carbs that I'm trying to give them to get them back up, right? Because I don't want them to be low for too long. So now I'm at 15 to 20 grams, again, waiting the 15 minutes, and then doing it again if I need to. Also, if you have patients where when they have a log, if you see them having numbers that are this low, and we usually do it if we see anybody that dips below 70 frequently, or our elderly patients, they need to be prescribed glucagon, okay? Because the glucagon is going to help them increase those levels more rapidly, and it's a good rescue to have, because if those glucose levels drop too low, they end up in level 3, which is going to be that severe altered mental status. They'll have, some of them may lose consciousness, and somebody else might need to administer the glucagon. So make sure that that is something that they have once they hit level 2. So you see your treatment here that they have is going to be the glucagon administration, or you can give them D50 IV, depending on what the setting is. But glucagon is usually the thing that they're going to need, because they're not going to be in a hospital setting most of the time whenever this happens. So all of this, don't need you to remember, except for this, right? If your patient they are unable to eat, if they are not having a lot of those symptoms, then that's whenever you're like, okay, I can give it to this patient. This patient is going to be the one who, like, you're asking them questions and they're not answering your questions properly. They're disoriented. Doesn't necessarily mean that they always have to be unconscious or, like, unresponsive in a way to talk, but, like, their altered mental status is the big thing that I want you to remember. Altered mental status. That is where they're going to have issues, and that's where they're going to need help. So, again, of course, they need to have glucagon prescribed to them. These are the oral things that they could do on their own. Carry candy. I don't know who's eating a spoonful of sugar, like Mary Poppins said, right? But, like, you can do different things, but most of the time you just tell them to have some type of hard candy on them so that they can bring those glucose levels back up. And most of your diabetics will walk around with that. We also have these glucose tablets. They would have to pay for these. I don't think we have these in the pharmacy anymore. This is more of an inpatient thing, and then this is what that glucagon would look like that you would have to prescribe. Most of the time we prescribe them in tubes if they're having to use this very often. That's your hint to say they're either not taking their meds or they're not well controlled, okay? So keep that in mind if you're having to prescribe this. Also, if you see one of these ordered for your patients, make sure it's not expired, okay? Because if they don't use it, it's kind of like an inhaler. If they don't use it and it's just been sitting there and it's been sitting there for 2 or 3 years, it's likely that it is expired, and then when they need it, it won't work, okay? So make sure that if you see this and it's been a while, that they check their expiration date. We'll start here tomorrow.